Welcome to the Hospital Medicine Unplugged podcast. Today we're doing a really critical deep dive into managing tuberculosis, specifically in the hospital setting. We've looked through recent international guidelines, top journals, clinical reviews, and they all seem to point towards the same urgent message.
Yeah, they really do. Managing TB effectively in the hospital boils down to speed, getting the diagnosis right quickly, and having almost flawless coordination between the clinical side and public health.
Absolutely. So the mission for this deep dive is pretty focused. We want to synthesize the current evidence on rapid diagnosis, aggressive management, and those really stringent infection control protocols that, hospitalists need to have down cold.
It's incredibly high stakes for us in the hospital. I mean, preventing spread within the hospital, nosocomial transmission, is absolutely paramount. And frankly, even with all our advances, the morbidity and mortality from TB are still, well, quite substantial. Shockingly so sometimes.
Yeah. So our goal here is to give you a kind of shortcut to the key evidence-based strategies. We'll be focusing quite a bit on the newer molecular tests and also the nuances of tailoring care for specific patient groups.
Right.
But before we jump straight into protocols, maybe we should just quickly recap the basics of the disease itself, how it presents, and why these patients end up on our wards in the first place.
Good idea. So fundamentally, TB is caught by inhaling these tiny aerosolized droplets that contain the bacteria, Mycobacterium tuberculosis. Once those little particles get down into the alveoli, deep in the lungs, that's where the initial interaction with the host immune system, mostly macrophages, begins.
And what makes the hospital setting particularly risky, and this is crucial, is the type of patients we often see. They're frequently immunocompromised already or critically ill, maybe dealing with multiple complex health problems.
Exactly. And that baseline state dramatically increases their risk of progressing from just a latent sleeping infection to full-blown active disease or, having a latent infection reactivate while they're under our care.
It's like they're sitting on a bit of a tinderbox, physiologically speaking.
That's a good way to put it. And the infectiousness itself drives so much of what we do, especially the isolation protocols. Active pulmonary TB, or PTB, that's the lung form, accounts for about 85% of cases. And the risk of transmission is highest when someone has cavities visible on their chest imaging. Those cavities often mean a very high number of bacteria are present, and they're being actively shed into the air.
And that single finding, or even the strong suspicion of it, is what triggers the absolute need for immediate, strict airborne isolation. No negotiation there.
Right.
So thinking about how these patients actually look clinically, classic pulmonary TB, especially in someone with a competent immune system, often presents pretty gradually, doesn't it?
It does. It's often that story of a cough that just won't go away, maybe lasting weeks or months, bringing up sputum, fevers, those classic drenching night sweats, losing weight without trying, that kind of picture.
And we're usually looking for that typical pattern on the initial chest x-ray, right? The upper lobe involvement.
Yes, exactly. In an immunocompetent person, the classic findings are those infiltrates in the upper lobes, maybe the apical or posterior segments, and crucially, cavitation, those holes in the lung tissue. But, and this is where it gets much more complex for us as hospitalists, we have to consider extrapulmonary TB, or EPTB.
Right.
This accounts for maybe 10 to 40% of cases, sometimes even a bit higher, and it's much more common in our immunocompromised patients.
And EPTB is famously tricky because it can show up in so many different ways. You can't rely on just lung symptoms.
Not at all. The presentation depends entirely on which part of the body is affected outside the lungs. It really demands a high index of suspicion, especially if you have a patient with a fever and you've ruled out the more common infections.
And some forms of EPTB are incredibly urgent, aren't they?
Absolutely critical. The most common site for EPTB is actually the lymph nodes, usually painless swelling, often in the neck, which might develop slowly. But CNS involvement, the central nervous system, that's a different story. Tuberculous meningitis. It might start subtly with headache, fever, maybe just some gradual changes in mental status. But this is a true medical emergency. Delay in diagnosis and treatment can lead to permanent neurological damage or death.
We also need to think about the structural damage EPTB can cause elsewhere.
Definitely. Spinal TB, also known as Pott's disease, can cause severe back pain and, very dangerously, neurological problems if the vertebrae collapse and compress the spinal cord.
And then there's the most severe form.
Right. Disseminated or miliary TB. That's where the bacteria spread through the bloodstream and seed organs throughout the body. These patients are often profoundly ill, looking septic, frequently with multi-organ dysfunction. They almost always require ICU-level care.
This really brings us back to the impact of a weakened immune system. For patients with HIV or maybe those on strong immunosuppressant drugs like biologics, the way TB presents can be very different, very atypical.
It really can. They often don't mount the same kind of immune response needed to form those classic granulomas or cavities in the lungs. So, consequently, they might have a much lower number of bacteria in their sputum, making some tests less sensitive.
Which means their chest x-rays can be totally misleading.
Exactly. You might see a completely normal X-ray, or maybe just some nonspecific things like infiltrates in the lower lobes or swollen lymph nodes in the chest, talar adenopathy. It's easy to mistake it for regular pneumonia or even something like lymphoma.
And here's a really startling point from the sources. Something like up to a quarter of these very vulnerable immunocompromised patients might actually have active TB but show few or no symptoms when they first come in. Subclinical disease. So if we just wait around for the classic cough and fever, well, we've potentially missed a critical window for the patient and risked exposing others in the hospital.
That realization that we can't always trust the classic symptoms or imaging is precisely what has driven the big shift towards faster, more sensitive diagnostics. Our whole diagnostic strategy now has to be about combining speed with the highest possible accuracy. Because, like you said, the clock is ticking both for the patient's outcome and for preventing hospital spread.
Okay, so let's unpack the current standard for actually getting the samples we need. Because even with new tests, getting good samples is still fundamental.
Right. The standard approach is still to collect at least 2, ideally 3, separate sputum samples. If the patient can't cough one up spontaneously, then inducing sputum using nebulized hypertonic saline is the way to go. We need those samples for the key lab tests.
And traditionally, what were those key tests?
Well, the traditional workhorse was the AFB smear acid-fast bacilli microscopy. It's fast, you can get a result in hours, and it's historically been crucial for making those initial decisions about infection control, about isolation.
But the big drawback?
Its sensitivity is just not great. It can miss, 50% or even more of active pulmonary TB cases, especially if the bacterial load is low.
Okay. And the other traditional pillar?
That's mycobacterial culture. This is still considered the gold standard for confirming the diagnosis definitively and, importantly, for testing which drugs the specific TB strain is susceptible to. That's phenotypic drug susceptibility testing, or DST. But the major limitation, especially in the acute hospital setting, is the time it takes. Culture results can take anywhere from 2 weeks up to sometimes 6 or 8 weeks. That delay is just, it's often unacceptable when someone is seriously ill or potentially spreading the infection.
And this is exactly where the practice has really changed dramatically. Nucleic acid amplification test nets, specifically things like the Xpert platform, using tests like Xpert MTB BRF or the newer Xpert Ultra. These are now recommended as the first-line diagnostic test.
Yes. This isn't just adding another test. It's fundamentally shifting how we approach suspected TB cases right from the start.
So what makes them so much better?
Several key advantages. First, they are rapid. You can often get a result within about 2 hours. Second, their sensitivity is much higher, significantly better than the smear microscopy. But the real game changer, the thing that lets us act decisively on patient safety and treatment, is their dual capability.
Meaning?
Meaning, they don't just detect the DNA of Mycobacterium tuberculosis confirming TB, they simultaneously look for specific genetic mutations, primarily in a gene called ARPB.
And why is that ARPB gene so important?
Because mutations in ARPB are the main cause of resistance to rifampin, one of our most important first-line TB drugs. And since multi-drug-resistant TB, MDR-TB, is defined as resistance to at least isoniazid and rifampin, finding rifampin resistance with this rapid NAAT test acts as a very reliable, very fast indicator, a surrogate marker for MDR-TB.
Wow. So if that test comes back positive for TB and positive for rifampin resistance within just a couple of hours,
you immediately know you cannot use the standard treatment regimen. You've avoided starting ineffective therapy, which is crucial for the patient and prevents further resistance from developing. It's a massive advantage.
That's incredible leverage from one test.
Yeah.
And the sources really emphasize how valuable these NAATs are in those tricky atypical cases we talked about earlier, the EPTB cases.
Absolutely. They're now standard practice for testing samples from outside the lungs, like cerebrospinal fluid, CSF from a spinal tap, pleural fluid from the chest cavity, tissue biopsies, fluid aspirated from lymph nodes. It allows us to confirm EPTB much faster than waiting for culture.
Okay, are there other specific diagnostic tools for certain high-risk groups?
Yes, particularly for patients with advanced HIV, usually those with very low CD4 counts, say below 100. There's an additional test called the urine liporabanamanin assay, or LAM test. LAM is a component of the mycobacterial cell wall, and it gets shed into the urine, especially when someone has widespread disseminated TB with a high bacterial burden.
And the advantage of the urine lamb.
It's fast, it's non-invasive, just a urine sample, and interestingly, it actually performs best in the sickest patients, those with low CD4 counts and disseminated disease. These are often the patients who are too ill to produce good sputum samples, so it adds real diagnostic value in that specific group. It's important to remember, though, while these molecular tests give us rapid detection and rifampin resistance info, we still absolutely need comprehensive drug susceptibility testing, DST, for all initial TB isolates. That guides the entire treatment plan.
So the rapid molecular DST is preferred first.
Yes. Platforms like GenXpert can often give quick results for resistance to several key drugs, but we still need the traditional culture-based phenotypic DST to follow to confirm susceptibility or resistance to the full panel of first-line drugs and sometimes second-line drugs if needed.
Got it. And what about imaging? Where does that fit in now?
Chest X-ray is still the first step for anyone suspected of pulmonary TB. It's quick, widely available, highly sensitive, meaning it's good at picking up abnormalities if they're there, but its specificity is limited. Lots of things can look abnormal on a chest X-ray.
So when do we need more advanced imaging?
If we suspect EPTB, or if the chest X-ray is normal or shows atypical patterns in an immunocompromised patient, then advanced imaging like CT or sometimes MRI becomes essential.
Examples.
Well, for suspected TB meningitis, an MRI of the brain is crucial to look for characteristic signs like basal meningeal enhancement and to assess for complications like hydrocephalus. For Pott's disease, the spinal TB, CT, or MRI of the spine is needed to see the extent of bone destruction and, critically, whether the spinal cord is compressed, which might require urgent surgery.
Okay, so that detailed diagnostic picture flows directly into the next critical piece, infection control. The guidelines are crystal clear here, aren't they?
Yeah.
Immediate airborne isolation is rule number one.
Absolutely zero wiggle room on this. Any patient with suspected or confirmed active pulmonary TB must be placed in airborne infection isolation immediately. The goal is preventing transmission to other patients, staff, anyone visiting the hospital.
And what does that entail practically?
It means putting the patient in a negative pressure room. Air flows into the room from the hallway, but is exhausted directly outside, preventing contaminated air from escaping into common areas. And anyone entering that room, doctors, nurses, respiratory therapists, housekeeping, must wear at least an N95 respirator or an equivalent that has been properly fit tested. Standard surgical masks are not sufficient.
These negative pressure rooms are often a limited resource, so knowing when it's safe to discontinue isolation is really important. What are the exact criteria?
There are 3 specific criteria, and the patient has to meet all 3. First, they must be on effective multi-drug therapy, meaning the right drugs that we know or strongly presume the TB is susceptible to.
Okay, number 2.
Second, they need to show clear clinical improvement. We're looking for things like fever resolving, cough lessening, producing less sputum. Basically, they need to be getting demonstrably better.
And the third, the microbiological one.
Third, they need to have 3 consecutive sputum smears that are negative for AFB.
And there's a specific timing for collecting those smears. Right.
Yes, this is important. The 3 negative smears need to be collected 8 to 24 hours apart. And critically, at least one of those samples must be an early morning specimen.
Why that specific timing, the 8-24 hours and the early morning requirement?
It's based on understanding how bacteria are shed. Sputum production and bacterial load can fluctuate during the day. Collecting samples spaced out over at least 2 days helps ensure the negative results are consistent and not just a random dip. And the early morning sample is often the most concentrated because secretions can pool overnight, making it theoretically the highest yield sample for detecting any remaining bacteria, so passing that one gives more confidence.
This is where those rapid tests really show their value again, isn't it? In terms of managing isolation.
Huge impact. Studies have clearly shown that using rapid molecular tests, like Xpert, significantly shortens the time patients spend in respiratory isolation, especially those who end up testing negative. Think about someone admitted with a cough where TB is on the differential but less likely. Getting a negative net result back in hours, rather than waiting days for smears or weeks for culture, allows us to discontinue isolation much sooner. That saves resources, reduces costs, and frees up that critical negative pressure room for someone who truly needs it.
That's a major practical benefit.
Yeah.
And we should clarify the rule for EPTB again.
Right. If a patient is diagnosed only with extrapulmonary TB and there's no sign of lung involvement, they generally do not need airborne isolation. The bacteria aren't being aerosolized from their lungs. However, if there's any suspicion of concurrent pulmonary TB, even if the main site is elsewhere, then isolation must be maintained until pulmonary disease is definitively ruled out, usually with those sputum tests.
Okay, so diagnosis is underway, isolation is in place. Now we need to talk about treatment. The sources emphasize starting treatment promptly, right? Even before all the results are back sometimes.
Yes, especially if the clinical suspicion is high or if the patient is severely ill. Waiting for full confirmation can be detrimental. Empiric treatment, based on the likely diagnosis and local resistance patterns, should often be started quickly.
And what's the standard go-to regimen for drug-susceptible TB?
The backbone for decades now has been the standard four-drug combination therapy. That's isoniazid, often abbreviated H, rifampin R, pyrazonamide Z, and ethambutol. The reason for using 4 drugs right at the beginning during the intensive phase is to hit the bacteria hard from multiple angles, maximize the killing effect when the bacterial load is highest, and importantly, prevent resistance from emerging during treatment.
And this standard treatment is divided into phases.
Correct. There's an initial intensive phase where the patient takes all 4 drugs HRZE every day for 2 months. This is followed by the continuation phase, which typically lasts for another 4 months. During this phase, the regimen is usually simplified to just 2 drugs, isoniazid and rifampin, HR.
Is there a point where we can streamline the regimen even sooner?
Yes, absolutely. This is about tailoring therapy and reducing unnecessary drug exposure. Ethambutol, the E in HRZE, is primarily included initially to cover the possibility of isoniazid resistance while waiting for susceptibility results. So, once drug susceptibility testing confirms that the patient's TB strain is susceptible to isoniazid, rifampin, and pyrazonamide, the ethambutol can and should be stopped. This often happens well before the 2-month mark if you have rapid DST results.
Okay, that makes sense. Now, we have to tackle the really significant challenge of drug resistance. MDR-TB, multi-drug-resistant TB. You mentioned it's defined by resistance to at least isoniazid and rifampin.
Yes, and diagnosing or even suspecting MDR-TB is a critical moment. We need to be hypervigilant for risk factors.
Such as?
Anyone with a history of previous TB treatment, especially if it was incomplete or failed. Anyone known to have been exposed to a person with drug-resistant TB. Or patients coming from parts of the world where MDR-TB prevalence is high. If any of those risk factors are present, it should immediately trigger the fastest possible drug susceptibility testing, particularly that molecular test, looking for rifampin resistance via the RPB gene mutation.
And managing confirmed MDR-TB, that's not something we handle routinely, is it?
Definitely not. It's highly complex and absolutely requires consultation with infectious disease specialists or dedicated public health TB experts. Treatment decisions are entirely driven by detailed DST results, often for both first and second-line drugs.
What's changing in MDR-TB treatment? I know there have been big developments.
Huge developments. We're moving away from the older regimens that often involve long durations, maybe 18, 24 months, and included injectable drugs with significant toxicities. The major shift is towards all oral regimens, often shorter in duration, based on newer and repurposed drugs.
Like the BPL regimen.
Exactly. The BPL regimen, which stands for bedaquiline, predoman, and linezolid, sometimes with moxifloxacin added, making it BPL-M, has revolutionized MDR-TB care. These regimens can often cure MDR-TB and even some forms of more extensively resistant TB in just 6 to 9 months with pills alone. It's a massive improvement over the older approaches.
That sounds like a huge step forward for patients in terms of tolerability and adherence. But these newer drugs aren't without their own issues, right?
No, they require careful management. Bedaquiline, for instance, carries a risk of prolonging the QTc interval on the ECG, so regular cardiac monitoring is essential. Linezolid can cause myelosuppression, affecting blood counts, and also peripheral and optic neuropathy, so monitoring blood counts and watching for nerve symptoms is crucial. It's a different set of monitoring requirements compared to the standard regimen.
And there's that absolutely critical warning about managing potential treatment failure.
Yes. This is like the cardinal sin of TB treatment. Never add just a single new drug to a failing regimen. If you suspect the current drugs aren't working, adding only one new agent basically allows the resistant bacteria that are already present to quickly develop resistance to that new drug as well. You risk creating even more resistance, potentially XDR-TB, extensively drug-resistant TB, and making the situation much harder, if not impossible, to treat. Any change to a failing regimen needs expert input and usually involves adding multiple new effective drugs simultaneously.
What about the less common scenario of resistance just to isoniazid, but susceptibility to rifampin, isoniazid monoresistance?
That still requires a modified approach, not the standard HRZE. The treatment typically involves rifampin, ethambutol, and pyrazinamide, often with a fluoroquinolone like moxifloxacin added. And the duration is usually longer than the standard 6 months, often stretching to 6, 9, or even 12 months, depending on the specifics.
Okay, and finally in this section, the importance of adherence and coordinating with public health cannot be overstated.
Absolutely fundamental. Directly observed therapy, or DOT, where a healthcare worker watches the patient take their pills, is still recommended globally, especially after discharge, to maximize adherence and reduce the chances of treatment failure, relapse, or resistance developing. And it's legally mandated everywhere. All suspected and confirmed cases of TB must be reported to the local public health department. This is essential for tracking the disease in the community, for initiating contact investigations to find and treat others who might have been exposed, and for coordinating that crucial DOT once the patient leaves the hospital.
Right, that public health link is vital. Okay, let's shift gears now to managing TB in specific, often complex patient populations, starting with a really important overlap: HIV and TB co-infection.
Yes, this is a major challenge globally. As we touched on, patients with HIV, particularly advanced HIV, are much more likely to have disseminated TB, atypical presentations, and even subclinical disease, making diagnosis harder.
And managing them involves tricky decisions, especially around starting HIV treatment, the antiretroviral therapy, or RT.
Exactly. The timing of starting ART in someone newly diagnosed with TB is critical, and it's primarily driven by the need to avoid or manage immune reconstitution inflammatory syndrome, IRIS.
Can you explain IRIS again briefly?
Sure. IRIS happens when you start ART, the immune system starts to recover, get stronger, and then suddenly recognizes the TB bacteria, or their antigens, that it might have been previously ignoring or only weakly responding to. This newly awake immune system can then launch a very strong inflammatory attack against the TB, which paradoxically makes the TB symptoms worse, or can even cause new symptoms or lesions to appear. It looks like the TB is getting worse, but it's actually the recovering immune system overreacting.
So how do we time ART initiation to minimize this risk? It depends on the CD4 count, right?
Precisely. The guidelines are quite specific. If the patient is severely immunocompromised, typically a CD4 count below 50 cells per cubic millimeter, the recommendation is to start ART very quickly within 2 weeks of starting TB treatment.
Why so fast if IRIS is a risk?
Because in someone that immunocompromised, the risk of dying from other opportunistic infections due to the low CD4 count is extremely high. That risk outweighs the risk of severe IRIS from starting ART early. You need to get the immune system recovering as quickly as possible, even while treating the TB.
Okay, and as the CD4 count is higher, say above 50?
If the CD4 count is higher, you generally have more leeway. ART initiation can usually be delayed until about 8 to 12 weeks after starting TB treatment. This delay allows the initial phase of TB treatment to significantly reduce the amount of bacteria and antigen in the body, which in turn lessens the severity of any potential IRIS when ART is eventually started.
But there's a key exception to these rules.
Yes, a very important one: TB meningitis. If the TB is affecting the central nervous system, you absolutely must delay starting RT much longer, often waiting until at least 4 to 8 weeks after starting TB treatment, sometimes even longer depending on the clinical course.
Why the delay specifically for CNS TB?
Because IRIS in the brain is incredibly dangerous. The inflammation within the closed space of the skull can cause severe cerebral edema, increased intracranial pressure, and lead to permanent neurological damage or death. The risk of harm from early ART-induced IRIS in TB meningitis is just too high.
Beyond the timing in IRIS, there are major drug interaction issues with TB meds and HIV meds, aren't there?
Huge issues. Rifampin, that key first-line TB drug, is a very potent inducer of liver enzymes, specifically the CYP450 system. This means it speeds up the metabolism of many other drugs, including a lot of common antiretroviral agents used for HIV treatment. It can drastically lower the blood levels of those ART drugs, making them ineffective.
So how do we manage that?
It often requires careful regimen selection. For some RT regimens, particularly those using certain protease inhibitors or non-nucleoside reverse transcriptase inhibitors, rifampin just can't be used safely. In those situations, we often have to substitute rifabutin for rifampin in the TB regimen. Rifabutin is a related drug, but is a much weaker CYP450 inducer, so it has fewer problematic interactions and allows the RT to remain effective. This requires close collaboration with HIV specialists.
Okay, shifting from HIV, what about patients with other organ dysfunction? Liver disease, for example.
High alert is needed there. Several of the first-line TB drugs, especially pyrazinamide, isoniazid, and rifampin, can cause drug-induced liver injury, hepatotoxicity. So baseline liver function tests, LFTs, are mandatory before starting, and then frequent monitoring of LFTs during treatment is absolutely essential, especially in the first couple of months. We need to watch closely for any signs of liver damage.
And kidney disease.
Patients with significant renal disease often need dose adjustments for some TB drugs, particularly ethambutol, and potentially some of the second-line agents if they're needed. And it's also worth remembering that patients with chronic kidney disease, especially end-stage renal disease, seem to be at a higher baseline risk of developing EPTB, likely due to underlying immune dysfunction associated with kidney failure.
What about pregnancy?
Generally, the standard first-line TB treatment regimen using isoniazid, rifampin, ethambutol, and pyrazinamide initially, although pyrazinamide use is sometimes debated but generally considered acceptable, is considered safe and necessary during pregnancy. The risks to both the mother and the fetus from untreated active TB are usually far greater than the risks of the medications themselves. But of course, close monitoring for side effects and toxicity is still crucial.
And circling back quickly to EPTB management besides diagnosis, are there specific treatments? You mentioned corticosteroids earlier.
Yes, for certain severe forms of EPTB, adjunctive corticosteroids are actually recommended, specifically for TB meningitis and TB pericarditis, inflammation around the heart. In these cases, the inflammation itself causes significant damage, and using steroids alongside the anti-TB drugs helps to reduce that inflammation, decrease morbidity, and prevent long-term complications like neurological deficits or constrictive pericarditis.
This really highlights the potential for severe complications from TB, especially in hospitalized patients. What are some of the high-risk outcomes we see?
In the lungs, we can see patients develop acute respiratory failure requiring mechanical ventilation. Massive hemoptysis, coughing up large amounts of blood, can occur, sometimes life-threateningly, and severe disseminated TB can trigger acute respiratory distress syndrome, ARDS.
And outside the lungs?
The consequences can be devastating and permanent. CNS TB can leave patients with lasting cognitive problems or neurological deficits. Pott's disease can lead to chronic pain, deformity, and paralysis from vertebral collapse. And disseminated TB, as we said, can progress rapidly to sepsis and multi-organ failure.
The mortality figures cited in the sources are quite sobering.
They really are. Overall, in-hospital mortality for patients admitted with active TB can range anywhere from around 13% up to over 40% in some studies, particularly those focusing on critically ill patients.
What predicts those poor outcomes?
Predictors consistently include things like older age, being critically ill requiring ICU care, having disseminated disease, underlying immunosuppression like HIV, and critically, any delay in starting appropriate, effective TB therapy based on susceptibility. That delay is a key modifiable factor.
That data really drives home the urgency we talked about earlier and leads us into the final section, monitoring and follow-up during the hospital stay.
Exactly. Once treatment is started, monitoring is key. Clinically, we need to be assessing symptoms constantly. Is the fever improving? Is the cough getting better? And we need to be actively monitoring for adverse drug reactions.
Like the liver toxicity we mentioned. What else?
Rashes are common. Neuropathy, nerve damage, often presenting as tingling or numbness in the hands and feet, is a known side effect of isoniazid. That's why pyridoxine, which is vitamin B6, is routinely recommended for all patients taking isoniazid, especially those with risk factors like diabetes, HIV, malnutrition, or alcoholism, to help prevent this neuropathy.
And how do we monitor the treatment's effectiveness microbiologically?
We need to follow the sputum results. After the initial baseline samples, the standard is to collect sputum for AFB, smear, and culture at least monthly until the patient achieves 2 consecutive negative cultures. Smear conversion going from positive to negative smears usually happens first and suggests reduced infectiousness, which is important for isolation decisions. But culture conversion is the true measure that the treatment is effectively killing the bacteria.
Some places might check smears more often.
Yes, in situations where transmission risk is considered very high, some guidelines suggest checking sputum smears perhaps every 2 weeks until they turn negative, just for closer monitoring of infectiousness.
What if the cultures don't turn negative, say after 2 or 3 months of treatment?
That's a major red flag. Persistently positive cultures after 2-3 months strongly suggest either treatment failure, perhaps due to non-adherence or malabsorption, or, very concerningly, the presence of primary or acquired drug resistance. If that happens, you absolutely must repeat comprehensive drug susceptibility testing, both molecular and culture-based if possible, on the recent positive isolate to figure out what's going on and guide changes to the treatment regimen, likely switching to second-line drugs.
And the lab monitoring for side effects needs to be systematic too.
Absolutely. Baseline LFTs, ALT, AST, and serum creatinine before starting the standard HRZE regimen. Then repeat LFTs usually monthly, especially in the early months, or more often if baseline tests were abnormal or the patient has liver disease risk factors.
Oh,
Creatinine should also be monitored periodically.
other labs.
A complete blood count, CBC, periodically is important, especially vital if the patient ends up on drugs known for myelosuppression, like linezolid, which requires very close monitoring of platelet counts and hemoglobin.
And for those newer drugs with cardiac risks.
Right, if a patient is on bedaquiline or potentially other drugs that can prolong the QTC interval, then regular ECGs are needed, along with monthly monitoring of electrolytes, specifically potassium, calcium, and magnesium, as low levels of these can increase the risk of dangerous heart rhythm problems.
Okay, so as we wrap up this really intensive deep dive, what are the absolute must-remember takeaways for hospital practice?
I think it boils down to that core triad we discussed. First, rapid diagnosis, ideally using molecular tests up front. Second, immediate and strict infection control, meaning airborne isolation for a suspected or confirmed pulmonary TB. And third, prompt initiation of the right multi-drug therapy tailored to susceptibility results as soon as they're available. If any one part of that triad fails, the whole system is compromised, putting both the patient and potentially others at risk.
And we constantly have to remember how comorbidities amplify the complexity.
Exactly. Managing TB isn't one size fits all. We need that individualized approach, paying close attention to things like the precise timing of RD in patients with HIV, potential drug interactions, and the need for vigilant toxicity monitoring in patients with liver or kidney problems. These aren't just details, they're critical for safe and effective care.
So maybe a final thought to leave people with. Considering those really concerning high in-hospital mortality rates, sometimes exceeding 40% of the sickest patients, where's our biggest opportunity to actually make a difference to improve those outcomes?
It's a crucial question, and I think the evidence points strongly towards time. While choosing the right drugs eventually is vital, our greatest leverage seems to lie in aggressively shortening the time interval, collapsing the time from the moment we first suspect TB to the moment the patient is on effective therapy that the TB is actually susceptible to and is appropriately isolated.
So the speed that comes with molecular diagnostics isn't just a lab convenience or a cost saver.
It's not at all. It's a direct clinical intervention. That speed, that ability to confirm TB and detect resistance within hours directly impacts patient survival and public safety within the hospital. That tight integration of rapid diagnostics, swift logistical actions like isolation and prompt, informed therapy that really is the core mission of modern, effective hospital-based TB management.